So I'm going to talk about just the immune system side of it. Obviously, you all are pretty well versed on all the other cardiac and the psychiatric issues. The objectives, quick little 15-minute presentation on the genetics, and of course you've heard different names for 22q. DiGeorge is something that we've always called that on the immunology side, and I'll tell you why it was called DiGeorge. We touched upon it just briefly just a second ago. Now, we'll talk a little bit about the thymus. We'll talk about what the immune cells are and why they're important. The related disorders that are also, just again, pertaining to the autoimmune and the allergic side. Treatment that we have for this. Vaccines, which is an important part of this too. And then some references you can look up online. All right, so the genetics. Now, the big difference is that, why do we say DiGeorge? Now, 22q11 is all the people who have that end up with DiGeorge, but the flip side is not necessarily true. So if you have DiGeorge, it's more than 90% of those people actually have the 22q11 deletion. However, there are less than 10%, obviously, that have other deletions. 10p14 is one of them, and some other ones that have been looked at. There's something about high glucose, but that's really not well described. Of the other more cardiac predominant features, 80 to 100% have the same deletion. So basically, I'm just saying it goes one way, but not necessarily. So cardiac anomalies, we've already talked about. The immune deficiency, now that's the big part of how you kind of get the name DiGeorge is if there's immunology involved, then you know DiGeorge. Hypocalcemia, again, from the embryonic issues that were discussed briefly before. And the nomenclature I just touched upon, one way but not the other way. Now the thymus, what is the thymus? Most of the time, people think of this little fat pad sitting on top of your heart as something annoying. Surgeons, especially cardiac surgeons, really get annoyed for when they have to do cardiac surgery. They're like, what's this in the way? They usually cut it out and throw it away. So at CHOP, which is where I come from, in Philadelphia, over there they pioneered the program where all the cardiac surgeries, which are a very important part of this, to not destroy the thymus. So actually, it's a lot more tedious, a lot harder to dissect out, but you actually dissect apart the thymus, leave it intact, and then you do all the cardiac surgeries. With that, you're able to help with the T cell side, the immune system side. The thymus, there's two parts of DiGeorge. Now, by far and in large, the most common is partial DiGeorge. And in partial DiGeorge, you have a decrease of your T cells, which are a very important side. You've heard of T cells in things like HIV and AIDS, where they kind of help mount the immune response. Now, 75 to 80% of infants have a partial phenotype, where they have a decreased amount, but not an absent amount. Now, the complete DiGeorge, that's the severe immune deficiency side. Less than 1%, thank God, but it's a big part because these people actually present as, you've heard of bubble boy, and that's basically what they are. They're considered like a severe combined immune deficiency. It knocks out their T cells, but also knocks out the other arm. So most of their immune system is actually knocked out. These children actually have a lot of issues, and for them, we actually have to do pretty early transplants, which we'll talk about it in the treatment side. Now, the fact that this 1% is important because a lot of times this, the 22q11 deletion is not diagnosed until after they receive certain vaccines, which this matters, and I'll talk about that. If you look at the actual T cell counts, like on CBC, their T cell counts will actually be normal. Even though they're normal, they're not necessarily completely functional because there's too many of a few instead of many of many, which I'll talk about. And the thymus size does not predict the T cell counts. So let's talk a little bit about T cells. T cells, they range from none, like I said, complete to partial, where they have pretty much normal numbers of T cells. The good thing is they do improve in the first year of life. Now, what I had alluded to previously was there's something we call the homeostatic expansion of T cells versus a generation of new cells. So in people who don't have this defect with the T cells, is you have all the T cells you make in your entire life, you make as a child when your thymus is there. So you might have 10 to the 9, 10 to the 12 actually. There's billions upon billions of different cells, and they're all like a lock and key. So you have a lock and key. You have essentially a key for any kind of lock that you may encounter in your life. If you encounter a virus when you're 50, or you encounter a virus when you're 3 years old, these T cells that you already have are going to randomly, just by chance, lock into it. If it locks in, it kills that virus. Now what happens is when that repertoire is decreased, instead of having a trillion different keys, now you're limited to having maybe a million different keys. So now if you get exposed to a virus that's not in those million, you have a higher chance of fighting it off. It's going to be harder to fight it off, harder to develop an immunity to it. So what happens in this is because the numbers may be correct, but you don't have the diversity there, you're going to be more prone to having certain infections. So the repertoire is what matters. We know this actually from studies we did with actually the Hiroshima and Nagasaki victims. Is we found out that unfortunately, when the nuclear bombs were dropped, all their T cells got labeled at that time. So when we looked at them again, and in adulthoods, we looked and see how many of those labeled T cells were still there, and we found that they're the only immortal cells we have in our body. So the T cells you develop as a child are the same ones that stay with you forever. So chemotherapy and things like that actually deplete those can affect your ability to fight off infections. Now, over here, there's also another small defect that they have found with a certain receptor which may involve the homeostasis of these T cells. Now, the B and NK cells, these are the guys that make your antibodies. So all the things you think about, vaccines and things like that, is all from B cells. They're usually intact. It's not impacted on for most patients, 99%. Only the complete DiGeorge or complete symptomology have a problem with B cells. There's an association of the deletion with IgA deficiency and specific antibody deficiency. There's an association. It's not causative. It's just associated. So they're more likely to have this. Now, IgA deficiency, very common, really doesn't affect anything. When we do a blood draw, the Red Cross has a bank of people who, when you donate blood, how many people actually have this, and it turns out it's like 1 in 154 people in the normal population have that, and it doesn't affect you at all. Specific antibody deficiency, what that does is it makes you more prone to certain organisms like pneumonia, maybe Haemophilus, Neisseria, certain organisms that your body can't recognize as much. In the past, all studies have shown NK cells, which are responsible for fighting off herpes viruses or molluscum or warts, is normal for the most part. However, there are some recent studies that say maybe there's a small defect in there, in the way they work. Infections. So clinically, what does this mean? So the most common infections we have are recurrent ear infections. And this is twofold. One is from the actual immune dysfunction, but also the other part is actually just physiological. As you already know, the palate can be dysfunctional, and because of that, there's a little more predilection to develop nasopharyngeal infections. And for that, you basically use antibiotics for that. The important thing to do is monitor for hearing loss, recurrent ear infections, and if there's a hearing loss, it can, of course, lead to the neurodevelopmental issues. So that is something to keep track of. Of course, recurrent sinusitis is the same kind of thing. There's a slight increase with recurrent bronchitis, either viral or bacterial, and pneumonia. Now, fungal, pneumocystis, and viral infections are only seen in the complete, so that's less than 1% of children are affected. Autoimmune. Now, this affects about 10 to 23% of children. Its mechanism is a certain type of T cell. It's called a T regulatory cell. This cell has been newly described in terms of medicine, I guess, in the last 20 years or so. What T regulatory cells are is they're the master, like their name implies, regulatory cell. All the other cells, all the other inflammatory disorders you have are from these cells not being able to regulate. So, example, if you have a lot of inflammation, they turn on to help calm things down. So once you have an infection, you have an immune response that destroys the infection. Once the infection is cleared, you want those cells to calm down so they don't cause destruction to yourself. What T cells do, these T regulatory cells do, is they come in and they calm the other post-inflammatory cells down. So that way they don't develop autoimmune disorders. In this, in the deletion syndrome, there's actually a defect in the T cells, so they're not able to calm things down after the inflammatory response. Again, there's a limited amount of them. Now for children, one of the things we see the most common is juvenile rheumatoid arthritis, ITP, which is autoimmune, which is basically the platelets get low. Again, anemia is for red blood cells, and then inflammatory bowel diseases. For adults, it's psoriasis, vitiligo, rheumatoid arthritis, and again, the ITP. Atopic disease, things we don't really think much about, but this is actually quite common. And it's just basically hay fever and asthma are big things. Eczema, you will also see a lot of too. So Th2 is a type of T cell, and you skew one way instead of the other. So they are actually quite prone to atopic disease. Initially, actually, one thing that's notable is food allergy is not on this list, which I actually don't know why, but it's not on there. So treatment, what do we do? Humoral, the B cell side, again, this is only for the less than 1% antibody replacement. Cellular, like the T cell defects, if it's the complete where it's less than 1%, we do a thymus transplant. This is done usually by Rebecca Buckley at Duke. They're the pioneers. And they're phenomenal at doing that. She has magic. She actually just touches people's thymuses and makes it work. I don't know how, but she's an amazing lady, so she's great. And then peripheral T-cell transplant, fully matched. And then antibiotic prophylaxis you have to have all the time until you get this. Regarding the screening test, if this does come up, then this is very important because the earlier you do this, the much better outcomes you have for all T-cell defects. Blood products, ever get a transplant, has to be CMV negative and has to be irradiated. I don't know if it's done here, but I know most centers have irradiated and CMV negative. Yeah, I haven't told it is here, so same thing. And then thymus-sparing cardiac surgery. Vaccines. Now, here's what's important. We've always never given live vaccines, and these are the list of live vaccines without having an immune system evaluation. And essentially, there are two main tests we need to look at. One is, do they have adequate T cells? CD8 cells more than 200, which correlates to about CD4 of 400. It's about a 1 to 2 ratio for children. And if you monitor proliferation, basically means if you stimulate them with a non-specific stimulant, basically, will the T cells grow? And in this situation, they need to. If they don't, that is a defect where we would recommend not giving live vaccines. The problem is, you don't want to not give them at all. We do have studies holding vaccines. What happens? And we found for varicella, just this one example, is 63% of unvaccinated children ended up with the infection. So really pretty easy, and this is usually fine. They have had retrospective studies on children that were diagnosed with 22q11 after they got the live vaccines, and actually the vast majority were fine. And again, it's less than 1% chance, but if it happens to be that, it's nice to know. Do we recommend routine titers? Are you talking about antibody titers for vaccines? No. So routine titers, we usually draw those just to see if people have responded to vaccines or if their immune system is capable of response. Titers don't necessarily correlate tightly with protection, with infection. Drug companies have titers in terms of getting the approval for the vaccine, but there's been very few. There's only one, like Prevnar 13 is one of the few vaccines that actually have shown decreased infection rates. Most vaccines don't have to show the rates per se. In case of this, if the T cells are fine with those two criteria that I mentioned, you can vaccinate. So for when it comes to vaccines, we're like vaccine all the time. The more vaccines, the better, because remember their T cell repertoire is going to be decreased. So at baseline, they're going to be at a higher risk of infections. So if you can vaccinate against whatever, and the vaccines again affect the B cell arm, so you're going to stimulate the arm that's not affected by the deletion syndrome. So now the T cell arm is where you want to try to help that as much as possible. So more vaccines the better. We're actually in the new front of vaccines. For the last, since the advent of vaccines, it's all been antibody vaccines, B cell vaccines, but now we're looking at T cell vaccines. So in the next 10 years, you're going to see a lot of brand new T cell vaccines which are actually going to be able to treat viruses and other. It's pretty neat actually, right, in terms of how we're working. The question is, would you wait? Would you give the rotavirus vaccine early, or would you wait to have your immune system checked? And I would say yes, check for sure. Any live vaccine, you have the chance. If you're in that 1%, then you're going to have the whole disease. You have fulminant, and like the actual wild type disease. So the question is, her child was told that she had an IgA deficiency and is prone to getting recurrent bronchitis, you said? Yeah. So the IgA deficiency itself can make you slightly more prone to infections, which when you're younger, you're going to have just because of diameter. So your bronchi, the tubes are small. So let's say you're an adult and your tube is about this big. You get an infection, you'll have some spasm. It's going to shrink up to about this big. You're out of space. If you start off with this much, and then you get a viral infection, you shrink with the swelling and the mucus production is smaller, you're more prone to getting a secondary bacterial infection. For those, it's really about clearance, unfortunately, and then should improve. I wouldn't really say the IgA deficiency is causative. I'd say it's more the T cells could make you more prone to viral infections, and because of that, it's causing the mucus production and all that to happen up. The main thing for that is pulmonary hygiene. How can you clear the lungs, make sure there's good cough reflex. If you can, your pediatrician can give you like some inhalers that kind of open up your lungs a little more. But you want to prevent the secondary bacterial. That's when the antibiotics kick in. Most viruses are over within 7 to 10 days. So 3 to 5 days is the worst. 7 to 10 is when you're kind of down off of it. By day 14, you should be back to normal. If the child is getting worse beyond 10 days, then you know a bacterial superinfection is taking place. So the question is, when are you more prone to hay fever? So atopy or just allergic diseases, the deletion syndrome gives you that. So just having 22q deletion, you're more prone to just environmental allergies, asthma, eczema, all of those things.
Because that's what we were noticing with my son. He was like all of a sudden out of the blue, he would be perfectly healthy and fine, and then all of a sudden out of the blue, he would get a really high fever, and then we would give him Tylenol, then he'd be fine the next few days, and we didn't understand it.
So hay fever means no fever. So that's a misnomer. If there's a fever, that's an infection. If there's ever a fever, there means there's an infection involved. If you have like symptoms like you're getting a cold, but you have no infection, no fever, not an infection. That's how you can tell the difference.